When thinking about cardiothoracic surgery, many people think of only the Hollywood, gory, open heart surgery and masked faces everywhere, tubes running to and fro, EKG beeping to the rhythm of the anxiety level in the room. And so this is a common misconception that people think that cardiothoracic surgery is, that it's only the gory aspects. And it's also a misconception that I walked into ISM this year thinking of. From whenever I can remember doing any sort of dissections, I've always loved being the first one to open up the specimen on the table and to really dig in to figure out what's going on. And so from that, I kind of discovered my love for, anatomy, human anatomy. And with that, I kind of carried that conception or that concept of the dissection to cardiothoracic surgery, which is totally not a dissection. Instead, it's a very specific field of research, a lot of analysis, and then at the end, it's the surgery aspect. And so throughout this year, I've learned so much about my field, surpassing the common misconceptions and learning about myself and my learning style, as well as really exploring the field pretty thoroughly, a field that really intrigues me. So allow me to start off explaining what ISM is to those in the room who don't know what ISM is. ISM stands for Independent Study and Mentorship. It is a program that allows students to explore a field that they really, really enjoy or have real interest in as a potential career in the future. And it allows students to take 1 year with the class time to really explore this field through a series of analysis papers, through real mentor visits, through interviews, through phone calls. And so it really refines professionalism as well as study the field. And so it's a really great opportunity for me this year to have been able to experience this medical field and to really see whether or not this is something I want to do. And it's really a great program for all students to experience. And so I would know that every ISM student would be able to say that it's a really great program that really allows students to study what they're passionate about. And after all, passion is what drives things from good to great. And allow me to move on to the processes that happen during ISM. So the first semester, what happens is we go on interviews and we write our resumes and we make phone calls and set up our interviews. And so that was all of first semester. And all of first semester I interviewed a total of 5 doctors with a series of a couple complications along the way. And then in second semester we found our mentor, and then we also worked on original work, which is essentially some sort of thesis or some sort of project that we worked on, as well as final product, which is what I'm really presenting today. Let me go through a little bit as to what I did during my first semester. So I really wanted to study immunology. It's something that I studied over the summer that I was able to do. And so I really wanted to incorporate immunology, cardiothoracic surgery, and find some sort of immunological method to reduce the amount of invasive surgeries that have to be done. And much to my dismay, when I went on my interviews, all the doctors said there's no real way, because the heart is indeed a sterile chamber, and the immunological system, while somewhat sort of related, isn't specifically directly related, and having to do something along the fields of that would be extremely complicated and hard. And so thus I resorted to my second field of interest, which is transplant surgery. So I went on a total of 5 mentor visits, first off with Dr. Matthias Peltz at UT Southwestern, second with Dr. Pietro Bayona, also at UT Southwestern, and then Dr. Christine Gillisarian, who is at the Children's Medical Center in Dallas, Dr. Catherine Harrington at the Baylor Heart Hospital in Plano, and Dr. Joseph Forbes in the Children's Medical Center of Dallas. And so initially, everything was going very smoothly. I've already decided my mentor way early in November, that Dr. Gillisarian would be my mentor. However, as we all know, things come more complicated than we expect, and so Dr. Gillisarian had to back out last minute after we sort of discussed the mentorship, because she had to go out of town a lot, and so, which is really understandable because she is, after all, a professional. So I went to my second choice, which is Dr. Matthias Peltz. He is at the UT Southwestern as a cardiac transplant director and he is my current mentor, and I'm extremely happy that I was able to have him as my mentor in the entire interview process and everything like that. With the phone calls, really taught me a lot. It taught me, one, most of all, patience, and second of all, persistence, because after all, I was able to get to the doctors only after calling them several times, leaving multiple voicemails, and so I've gotten my voicemail sort of speech good already practiced, as well as my persistence and patience in dealing with the office managers and the secretaries, and I'm really appreciative of them, don't get me wrong, but honestly that was a lot of patience, a lot of work that went into getting these interviews. And so I just want to talk a little bit about Dr. Peltz and why he really struck out to me as the person who I wanted as my mentor after Dr. Gillisarian. He talked a lot about the lung and heart preservation technique. In addition, he was also the director of the cardiac transplant program, which is something that I really wanted to study. And so my first interview with Dr. Peltz was extremely terrifying, because he's really domineering in his presence, because he's, after all, the director. Not only that, but he's also extremely knowledgeable, which is not a surprise, but it's just kind of scary sometimes. But he's a really good mentor, and I really appreciate him. And so what we worked on for the first semester is original work. And what original work is, it's supposed to be a thesis-like a thing where we get to think of something original and sort of carry it out as a process. And so what I did was a comparison of transplant types. So many people would do analysis, would do surveys, but I chose to go a different route and kind of go with a challenge to do an analysis of 2 different kinds of transplants. And so before I talk a little bit more about my original work, allow me to talk about what heart transplantation is. So who would need a transplant? A patient with end-stage heart failure would need a transplant, so someone who can't really breathe well doing day-to-day exercises, who can't really function, who either have suffered previous injuries to their hearts, they would need a transplant. And so because of the limited donor supply, we have to have very stringent candidacy tests. And so the patients go through an extremely long process to ensure that they are a candidate for one, and then they wait on the waiting list to have the new heart. And many people don't like doing heart transplantation because, after all, it's open heart surgery, which poses a huge risk to any kind of patient on the operating table. And so a lot of people have strayed as far away as they can from transplantation, but ultimately, after all, like, some diseases are unoperable unless there is a new heart in place. And so that's why heart transplantation is still prevalent, and the risk of its death rates or prognosis is about 85% success rate, and there's a 15% chance of failure, but it's still really good odds considering the patient is literally on the table with their heart in the open. And so heart transplantation candidacy tests are extremely stringent. I'm just going to bring up about 2 things that they really look at, which is 1, end-stage heart failure. They want to see if the patient is really in the need for the heart, and 2, their VO2 levels, which is their oxygen levels in the blood system. And so because the heart pumps the blood that brings the oxygen around to the body, they measure the amount of oxygen in the body to see whether or not the heart is pumping the blood at the correct rate and whether or not it is working properly. And so because heart transplantation has so many risks and it is a very dangerous procedure, there are a lot of contraindications, which means that if they have one X thing, they can't have the transplantation. So one of them would be liver failure, another would be renal failure, another would be if they only need a left ventricular assist device, because the donor supply is so limited that they want to give the candidate who would best benefit from the heart the donor heart. And so there's so many tests and so stringent, so that way they want to find the best candidate and they want to do the best procedure to ensure the best for all the candidates. So heart transplantation itself has many different types of transplantation procedures. There's heterotopic, there is total, and there is orthotopic. And so each 3 of these types have their own unique benefits and pros and cons to doing it. Heterotopic is actually a kind of weird procedure that not many have heard of, which is actually not fully taking out the heart, but actually attaching a second heart, so the patient will have 2 hearts. And so that's mostly used when there's a left ventricular problem, and because of the result of technology that we have today, we don't really need to have a heterotopic procedure because we have the left ventricular assist device. However, this procedure is used if there's a mismatch in the donors or if there's a really dire need for a patient to get a second heart. And so essentially a patient lives with two hearts, which is kind of weird because the body is supposed to only have one, but two hearts are in the chamber, and that works for the patient, but it's a very rare procedure that doesn't happen often today. The second one would be the total heart transplantation, which is completely taking out the heart, removing everything, including the vessels, including the atriums, the ventricles, removing the entire thing and placing an entire new heart in. And so this total transplant is really time-consuming, and because the longer the heart is outside of the body, it's called ischemic state, the worse the heart is in its condition in the new recipient or patient. And so those two techniques are not used very often, but they can still be used, but just not very often. And so what I decided to study today, for my original work, was the orthotopic technique, which is another technique for transplantation, but instead of taking the heart entirely out of its chamber, we leave either just the atrium or we leave both of the atriums. And so those are called biatrial or bicaval technique. And so we have three different techniques, which is one would be the heterotopic, one would be orthotopic, and one would be total. And under the orthotopic technique, there's two types of techniques, which is biatrial and bicaval. And so my original work is studying the difference between the two and why doctors should choose one over the other. And so biatrial, as it mentions in the name, is two atriums. So instead of taking out all of the atriums, we leave two atriums inside because we have a left one and we have a right atrium. And so we leave both of them in the recipient while the donor has the new ventricles and the aorta and everything. So it's only the two atriums left inside the body, whereas the bicaval takes out one of the atriums. And so we're left with one of the atriums inside. And so it seemed like a small difference, just left and right, just one atrium, one another, but it makes a really big difference in the amount of time the heart spends outside of the body, the amount of stitches that the surgeon needs to input, and a lot of other complications that occur during the surgeries. And so I want to compare these two techniques. So my proposal was to compare the two. My purpose is to prove the bicaval technique is superior to the biatrial technique, and my process is by collecting a lot of data from online. Because I'm physically unable, or not certifiably unable, to do the actual transplantations, I collected my data from online, and I'm unable to get access to the UT Southwestern data because it's confidential and they don't really want me to use their patients' data, so I had to get mine from online from published papers, and so that took the majority of my time. So it was the research about the actual transplantation and the gathering of the data that took the most time, as well as the analysis. So I had 5 parameters when I was looking at which technique is better than the other. One would be perioperative death, which means the death within a couple weeks of the transplantation. Second would be arrhythmia, because arrhythmia is commonly associated when we have ventricular dysfunction. So the heart, instead of beating its normal lub-dub, lub-dub, it gets lub-dub with a lot of space, or like it gets a really prolonged beat, and so that's really detrimental to the patient's health. In addition to perioperative death and arrhythmia, I also looked at the need for pacemakers, which is follow-up for arrhythmia. And sometimes if the patient has really bad arrhythmia, they need to have the pacemaker. However, if they do not have bad arrhythmia and have it just for a couple days or so, they don't need the pacemaker. So I looked at the pacemaker, and then I looked at right ventricular function, which is kind of measured differently in each paper, so I had to go through that, as well as ischemic time, which means the amount of time the heart is spent outside of the body. And so what happens when we remove the atriums is we cut the sinoatrial node. And so the heart has its own sort of electrical system, and so the heart is able to have its electricity pumped through both the atriums and the ventricle in order to have the blood pumped out. And because such, the atrial node, sinoatrial node, the atrioventricular node, is really important in maintaining the electricity of the heart, and so the ventricles pump correctly, and then the right atrium and left atrium are also in sync. And so biatrial and bicaval differ in the amount of atriums they take out. So biatrial takes out 2 and bicable takes out 1. And so when we take out that 1 atrium, we kind of preserve the sinoatrial node of the donor heart. Whereas if we leave the 2 atriums of the donor heart, of the recipient heart, we're cutting off the sinoatrial node and the electrical current between the donor and the recipient. And so that's the main difference, and that's really what I believe is a root cause of the difference in the 2 surgical procedures. And so when we look at perioperative death, I took a sample of 4 different studies because I couldn't have a uniform study because I had to grab all these numbers from different places, and found out that bicable data had the longer time, had the lower perioperative death percentage. And so there's one outlier in my data, so I kind of ignored that. But other than that, all of the data points to a higher perioperative death percentage in the biatrial technique. In addition, arrhythmia showed that more patients with bicable technique had, more patients with the biatrial technique had arrhythmia problems due to the cut in the sinoatrial node than bicable technique, and thus there's a correlation between the arrhythmia as well as the pacemaker, which proved that permanent pacemakers in biatrial patients was more because of the lasting arrhythmia. They need to have the pacemaker there inside to fix the arrhythmia. And the pacemaker is another hassle that patients need to go through because not only do they need to have the new heart transplanted, but they also have to ensure that they don't have or they do have arrhythmia. And when it is confirmed that they do have arrhythmia, they need to go back in to put in the pacemaker, which is placed on top of the heart. And so that causes a whole nother surgical process, which causes the patient a lot of hassle. In addition to that, they also suffer from arrhythmia. And so we can see the trend right now is really not in favor of the biatrial technique. And if we keep looking, we see right ventricular function, which is measured in right atrial pressure, so mmHg, which is measured in millimeters of mercury. And so if we see right atrial pressure, we want a lower atrial pressure because the higher the pressure, the more likely we'll have dysfunction because the heart is misshapen and the more blood needs to be pumped through. And so we want a lower pressure, which means a healthier heart. And if we look at the data that I collected, we see that the bicable technique has a significantly lower right atrial pressure. And so the normal right atrial pressure should be around 5 to 10 millimeters of mercury. However, if we look at the bicable technique data, it's all above 10 with 11 with 13 millimeters of mercury. And so we see once again that the bicable technique has the better advantage. In addition to right ventricular function measured by right atrial pressure, we can also measure right ventricular function by right ventricular end diastolic measurements. And end diastolic measurements are the measurements of the heart when it's fully expanded. So there's the maximum amount of blood inside, and because the heart is really it's really in proportion to the pressure and the measurements that it has. The amount of pressure in the right atrium really affects the right ventricle as well. And so because these two are interrelated, we can see that the end diastolic measurements of bicable data is lower once again, and that's what we want because we want a lower pressure and we want a lower measurement. If we have high pressure, we distort the size of the heart muscle, and we have a bigger heart, which ends up with dysfunction of the ventricles, with the right ventricle, with the left ventricle, and ultimately, if there's disruption in the left ventricle, we're not able to get blood to the rest of our body. And because such, we see, once again, with the right ventricular function data, that we have a bias towards the bicable technique, which leads me to my next point. If we have so much overwhelming evidence that bicable technique is superior to biatrial technique, why do we still have biatrial technique, which comes down to one of the most important reasons? Ischemic time. And ischemic time is defined as the amount of time the heart tissue is outside of the human heart, so inside the human cavity, so the amount of time that it doesn't have oxygen in in the muscles. And so the longer the heart is in ischemic time, which is measured about an average of 128 minutes, the worse the heart gets in terms of function. So surgeons always try to preserve the heart under 128 minutes. However, that's not always possible, because if we live in a country as small as Taiwan, we can have the heart transplanted from north to south in less than 4 hours. Whereas if we wanted a heart transplanted or heart flown from, I guess, New York to California, that's way more than 3 hours. And so it really depends on the size of the country, and that's why the data is a little bit skewed because of the bias in the countries. And so but we can still see the amount of time during bicaval versus biatrial. We can see that the bicaval ischemic time is longer. It's kind of a shift in the data because it's kind of different from the rest of the data that proves bicaval is better. This one proves bicaval is worse because it takes more time outside of the body, so it's not pumping. And the reason is because that we're removing only one of the atriums, and so the amount of anastomosis, which is the stitches that need to occur, are more, and so the surgeon needs to take more time to reattach the donor heart to the recipient, and this causes more time outside of the heart, outside of the pumping. And so we can see that at the end of the data, all of the conclusions, we see bicaval is clearly superior to the biatrial, with the exception of the ischemic time. And I believe that that's one of the major reasons why not all surgeons are using the bicaval technique, because if the ischemic time is well over 3 hours or 2 hours, it impacts the function of the heart, which ultimately affects the liver and the kidneys, and so the patient can go into renal failure, which is definitely not something that the patient should experience. And so that's my overall conclusion for my original work, which kind of leads me to my final product and my mentorship. After my original work, I went into Dr. Peltz's office a lot more for more mentor visits, mostly in his office because UT Southwestern has very stringent rules on who can go into the hospital to shadow. So there's a lot of work, documentation, and processes that need to take place with immunization records, HIPAA testing, course taking, etc., and a lot of signed papers and documents. And so I wasn't able to shadow Dr. Peltz for quite a while. But when it got closer to my final product, which I will explain in a little bit, I got to sort of edge my way into Dr. Peltz's shadowing a little bit more because I was able to pass through all the stringent rules that UT Southwestern has. Nevertheless, I'm not complaining that I wasn't able to shadow him. I really appreciated every second I had in Dr. Peltz's office because every second was like I was like a sponge soaking in information because I was learning so much because he had so much to offer. And so my original idea for final product was to make a survival calculator of some sort. So what I would do is take all the statistics that Dr. Peltz has from UT Southwestern and the clinical data that he's able to get his hands on, put it in some sort of model, and make an application that would kind of define or would clearly dictate what the prognosis for each patient would be if they needed a transplant. And the clinical data would include things such as the year of birth, age, as well as BMI, as well as blood pressure. So all the clinical data would be collected in some sort of and amalgamated into some sort of model, and I'd have the help of a biostatistician. And so that was my original plan, but it took way too much time as well as too much documentation through the department. And so what I ended up doing was doing a case study. And so my case study is focused on heparin-induced thrombocytopenia in the presence of purulent infectious pericarditis and a heart transplant. And so what essentially happened was I went into Dr. Peltz's office and I asked him, Dr. Peltz, what can I do for my final product because the first idea didn't work. He said he had a very interesting case that he had in mind, and so what I decided to do with that case was to write it in the form of a case study. So when we have scientific journals or cardiothoracic surgery journals, they have pages of papers, but at the end they also have case reports in which doctors are able to write up a report and sort of explain what happened that was a complication in the surgery, something that's unique, something that hasn't really happened. And so what we did here was we had two major issues or complications that happened for the patient. He had one, infectious purulent pericarditis, which is infection of his cardiac chamber, the sac around the cardiac chamber. And so what happened was he got a propionibacterial infection, which means that he, when he had his first surgery, his pericardium got infected, which is one of the first major problems. But second of all, he had an immune response for heparin-induced thrombocytopenia, which means that he's developed antibodies against heparin, which is an anticoagulant agent for his blood. It's a blood thinner, essentially. And so when patients are in surgery or when they're getting a transplant, they need to be on blood thinners so that there's not the production of thrombosis, which is a blood clot, which would travel around the body and cause all sorts of damage and become an embolism. So my case report is tackling the two of those in addition to a transplant. And so it's a very interesting case study. And when I finish my product, I'll get to explaining how I was able to do that and why I was so interested in the end result of the product.